This is DC EKG, exploring the intersection of politics and healthcare by diagnosing Washington and prescribing solutions. We take a deep dive into the legislation, regulation, and innovation impacting policymakers, providers, and patients. Now, America's health policy expert, Joe Grogan. In this episode, Joe steps to the other side of the mic. The team at The Hill, the Washington-based news and policy outlet, recently sat down with Joe for a conversation on how Medicare policy is blocking earlier Alzheimer's diagnosis and what it's going to take to change that.
Please welcome to the stage Kathleen Koch, a contributing editor at The Hill.
Good morning, everyone. And wasn't that a poignant story? I think it's probably familiar to a lot of us. I know my mother-in-law passed away from Alzheimer's. Anyone else have family members with the disease? Yeah. Well, I'm going to welcome someone to the stage to do a deeper dive into what's going on around the policies regarding these Alzheimer's therapies and tests. So please welcome to the stage Joe Grogan. He's a non-resident senior scholar at the USC Schaefer Institute, former director of the Domestic Policy Council, and former assistant to President Trump. Welcome.
Thank you. Thank you.
So, Joe, your years in the Trump administration, when you were head of the Domestic Policy Council, you also headed up domestic health spending at the Office of Management and Budget. I imagine that gave you a real insight, a real understanding for the drug approval and access process, and also the way federal law can either help or hinder that, or federal processes. So what is your take on the current debate right now on allowing Medicare to cover these blood-based biomarker tests for Alzheimer's?
Yeah, thank you, and thanks for having me. And Sue, that was a great conversation. I can't think of a better way to start this discussion. I'd say, my experience goes back even further than just the first Trump administration. In the Bush administration, I headed up the Presidential Advisory Council on HIV and AIDS. And I don't think this current debate is any different than we had at the dawn of the HIV epidemic, when there was a lot of pressure put on the government not to push screening for HIV because there weren't, at the time, quote, effective treatments for HIV. So there was a huge push at the beginning of the HIV epidemic that screening and testing for HIV was a waste of time.
So you're saying the same thing is happening with Alzheimer's because there's not a cure? I mean, there are treatments.
Sure, there's great treatments. I think there's two things going on, and I'll say this, same thing happened with hepatitis C as well. I was at Gilead Sciences when we launched a very effective cure for hepatitis C. There was a ton of pressure on the part of payers that disparaged the treatments and said these treatments aren't any good. Before there were really effective treatments, there was a lot of pressure not to screen, even though lifestyle changes could affect disease progression. And I think the same thing is happening now. There is a real need for people to screen and gain the knowledge to make the lifestyle changes that they can make, number one, and then figure out whether or not the treatments that have been approved by FDA, donanemab and lecanemab, are right for them. They're not right for everybody, but they show real promise. And unfortunately, I think there's pressure on the part of payers to disparage the FDA approval process, as there was with the HIV treatments when protease inhibitors were first approved and payers said these things don't work, it's a waste of time. Same thing with the hepatitis C medications when they were first approved. And I remember in the hepatitis C debate saying, do you think we have a problem paying for these? Wait till we get treatments and cures for Alzheimer's, because we have over 7 million people.
So you saw this coming.
Absolutely. And we saw it in the Biden administration when they said they put massive, as the gentleman referred to, huge restrictions on access to these drugs, and then blamed premium increases that didn't, there were no justification because it was very little access, premium increases on the Alzheimer's drug approvals. And we're seeing it again.
Let me ask, so the treatments, though, that currently exist are only effective in the very early stages of Alzheimer's, correct? So it would seem to me that would make a greater case for proving these these early diagnostic tests.
Yeah, it's a really good point. The science is evolving to show exactly that point that you're making. And we're having this debate right now around pre-symptomatic or stage 1, stage 0 even Alzheimer's, because you can start to have the physical manifestations within your brain before your family notices or you notice that you are declining. So the treatments, and we're starting to see, are demonstrating promise for early treatment to affect disease progression. But even separating the drugs for a second, and there's a ton of new drugs that are in development right now, you can make lifestyle changes, cutting alcohol down, more exercise, changing your diet to push your time out before you need more medical care, perhaps even going into a dementia home, spend more time with your family. And that can save taxpayers millions of dollars if we can keep people healthier longer. I was just out at the University of Southern California. Their estimates now are about $780 billion that we're spending on Alzheimer's. And that number is going to go up well over a trillion and a half, maybe 1.7 trillion over the next 20, 30 years. So if we can delay disease progression and keep people in their homes with their families longer, we can not just save taxpayers money, but keep families together longer.
So help us understand this delay that occurs. So the FDA approves a drug, a treatment for Alzheimer's, but then there is this delay time before CMS says we will cover that. Why does that occur? And I mean, I understand you did an op-ed in 2024 arguing for I guess donanemab, one of the treatments, because it had been approved by the FDA and CMS is like, nope, we're not ready to cover it.
Yeah, this has been it's an ongoing frustration of mine. And I worked a couple of years at the FDA as well, and it's a fantastic place to work and just amazing people working there. You know,
and amazing people work at CMS. My husband used to work there. So
that is true
have to put that plug in there.
That is true too. You know, there always is this push to second guess FDA approvals for any number of reasons. And again, a lot of times the payer community will second guess the scientific rigor with which FDA approved. And there are accusations of corruption, there are accusations of shenanigans, incomplete data files, that is often unjustified. There are mistakes made, I'm not saying there aren't. These drugs need to be continuously monitored.
And this is to justify them not covering them right away?
Absolutely, and CMS does have a different mandate. And I'm a budget hawk, you know, having been at the Office of Management and Budget. But they do have a different mandate to not pay for unnecessary treatments. But sometimes that leads to them second guessing FDA's rigor and scientific judgments. And I think that's happened with some of these, with the treatments. But with the screening tests, it is a mess. The diagnostics frequently take a lot longer. Devices take a lot longer for coverage at CMS.
Why is that?
Well, it's a long, the staff is they don't have enough staff there, number one. They have a different governing statute. It can take years and years to cover these. FDA approved these tests for diagnosis, so they can be paid for by Medicare after your physician says, we think you have Alzheimer's, you're demonstrating these outward symptoms, so they can order the tests and Medicare can pay for them. What they can't pay for, though, is the screening, using the blood-based test for screening. So before these tests came on the market, you needed a spinal tap or a PET scan. But we're at the stage that these tests are so moderately invasive, you know, just a blood biomarker, that they should be part of routine Medicare screening, annual screening. And then, because when you're talking about 8 million people that have this disease, you're talking about a lot of Medicare beneficiaries and a lot of people aging into Medicare that would benefit from having the knowledge that, hey, you are on track. If you make the lifestyle changes right now, you can improve your disease progression, and we can monitor you so that when you are eligible for the drugs that are approved now or the next wave of drugs, we can get you on appropriate treatment.
So if the test is covered, if it is used as a diagnostic, when you already have symptoms and you've seen your doctor about it. But if you're one of those people who say it runs in your family, like, I'm just curious if I might get it someday, then it falls into the prevention category, and that's not covered.
Exactly.
Okay.
Exactly. The CMS only in very rare circumstances, including as referenced, colorectal screening because Congress stepped in, they don't pay for prevention, which is counterintuitive, right? Because you want seniors to be as healthy as long as possible and be as active as possible, productive at work, with their families longer. So that's why the ACEP Act is so important, to keep these families together, keep people working for as long as possible. And frankly, I think it's a cost saver. This is penny wise, pound foolish to not pay for these screening tests.
So is the ASAP Act really then the best way to get these covered? It's going to take an act of Congress?
I think it is going to take an act of Congress. I think that CMS, if they just go through the normal process, it will take years and years that we frankly don't have. The ASAP Act is one of the most necessary pieces of legislation that I've seen. I saw Congressman Buchanan comes in, and I was sorry to see that he's retiring, but I hope that he can get this done this year before he's leaving, along with Congressman Tonko, because it is the best route we have to getting screening for Alzheimer's.
Now, I'm curious, there's something called CED, and that's coverage with evidence development. Now, I understand that allows CMS to cover a new or groundbreaking drug or procedure while, additional evidence is collected to answer questions or uncertainties. Why would that not work in this case?
Well, CED was originally developed in the Bush administration in order to do exactly that. Speed new treatments, mostly screening tests and devices into coverage while the evidence base is built in the real world. Unfortunately, CMS has used it to restrict access. And I was an early supporter of CED. I've become pretty much a hardcore opponent of it, because it is really, some of these CED restrictions are in place for years and years. There's some that go on longer than a decade.
So what does it do? Then drugs or treatments end up in tests in limbo?
Yeah, they ultimately end up in this sort of hyper-restricted zone of CMS coverage. And CMS doesn't have enough staff to review whether or not the data has manifested itself to repeal it. They don't make a big effort to repeal it and get wider access, and they are worried about the cost implications if they do. So it's not just confined to this screening test. I've been opposed to CED for years. Currently, all the amyloid plaque inhibitors are subject to coverage with the evidence development right now, and it's very restrictive.
Well, Joe Grogan, thank you so much for coming and taking the time to help bring some clarity to this very complex issue. Really.
Thank you so much.
Thank you.
For more conversations that get to the heart of healthcare policy, follow us on Spotify and Apple Podcasts. DC-EKG is executive produced by John C.Z. Swartacki and sponsored by Survivors for Solutions, a Stay on Course Studios production.